Welcome everyone to this week's Echo session. I hope everyone's having a good afternoon. We're excited to deliver this content to you today. Today's session is on acute chest pain, focusing on myocardial infarctions. My name is Bethel Wednesday. I'll be your moderator this afternoon, and I'm going to go ahead and let our panelists and experts introduce themselves, starting with Dr. Connie.
Good afternoon, everyone. I hope you're having a good afternoon. I'm called Dr. Baluka Koni, an emergency medicine resident from Makerere University. Thank you.
Hello, everyone. My name is Samuel Chitoleko. I'm a critical care nurse from Uganda Heart Institute in Mulaga Hospital. Nice to be here.
Thank you. Dr. Happy, you can go ahead and introduce yourself. Dr. Happy is one of our experts. She's a cardiologist who's going to be online. Dr. Happy, I think you're still muted. There you go. We can't hear you. No, we still can't hear you. Maybe we can have Dr. Solomon introduce himself. Dr. Solomon, we can't hear you, but 1 second.
It's our problem here. I think it's from our side.
Okay, Dr. Solomon, thank you for your introduction. I think Dr. Mbabazi will try again. I see people complaining about being unable to hear us. Is it us that you can't hear, or? They can hear? Okay, perfect. Perfect. Okay. So Dr. Solomon is our case presenter today. And like I said before, Dr. Babazi is going to be one of our expert panelists today. Lastly, we're going to have an introduction from Mr. Agave.
So, good afternoon. I would like to thank you for logging on every 2 weeks and be with us for this 41st session of the Emergency Medicine Echo. We thank you for taking the time to improve emergency medical services in the country. If you've been with us for a time, you know about the REACT teams, which are REACT teams, Resuscitation Action Teams. These are a group of health workers that we are equipping with knowledge, skills in the different health facilities to be able to respond to emergencies. I'd like to inform you, many of them have undergone back training, and many more trainings are organized until we cover all REACT members. And these REACT members are meant to cascade these skills and information to the rest of the staff members in their hospitals. We've also purchased and procured emergency kits, and these will be distributed in your facilities very soon. Thank you and have a great session.
Thank you so much. I hope you all were able to hear all that information. As you all know, before the session starts, we like to do a pre-test so we have an idea of where we are knowledge-wise before our experts get into the content. So please go ahead and take the pre-test that will be available on your screens, and the sooner we do it, the sooner we get into the session. And if you finish taking the pre-test, then please in the chat tell us your expectations, what you're hoping to walk away with after this session, what you're hoping the panelists touch on, any things you're excited to know concerning acute chest pain. So now would be a good time to make sure we're doing those pre-tests and writing out our expectations. Hello, everyone. Again, please answer the pre-test questions and type in the chat and let us know what your expectations are for the session today. I see some people are joining from Nigeria. Welcome. Thank you for being here. Please let us know if you can't see the pre-test. It should show up automatically on your screen right now. There is no separate link for letting us know your expectations. Just go ahead and write them in the group chat. And thank you for sharing. I'm seeing a couple of people talk about how they are expecting to learn new guidelines on the treatment of angina, both first aid and medical management of MIs, learning ECG variables in a typical STEMI case and when to refer patients for PCI. And then there are a couple of people also wanting to see management of acute coronary syndromes. So thank you. We're done? Okay. So you can keep letting us know your expectations, and I think everyone must have answered their pre-test. So we're going to move on and get into the session. Maybe before I can reintroduce Dr. Solomon. Dr. Solomon is a medical officer at Ginger Referral Hospital, and he will be the person doing our case presentation today. So he will be coming up next. So pay attention, write your questions and concerns, and we'll get into that after his presentation. Dr. Solomon, you're up. Dr. Solomon, we can't hear you. Mm, I think I hear you. Dr. Solomon, we can't hear you. For our online participants, you can keep pouring in your expectations and be patient with us while we figure out Dr. Solomon's audio. Thank you.
Can you hear me now?
Yes, perfect.
Thank you. So sorry for that disruption. I'm here presenting Mr. HJ, a 43-year-old male. He was a non-hypertensive on unknown medication since he presented without any documentation. However, he was not diabetic. Came complaining of left-sided chest pain, which had started 2 hours prior to his hospital arrival.
Dr. Solomon,
Yes, please.
would you mind changing your screen into presentation mode, clicking the slideshow so that it can be full screen for the viewers?
It's on, it's not on full screen.
Yes.
There?
Yes, but if you could do it, how do I direct you? Slide, yeah, yep, right where it says slideshow. No, yeah, that one.
The slideshow?
Yes.
Yeah, that's where we are, and that's where I am.
Okay. Our technical team is saying they can project for you. Is that okay?
That's okay. That's perfect.
Okay, but you can continue presenting.
Okay, please.
Yes.
So I'm presenting. Can you hear me?
Yes, we can.
Mr. HJ, a 43-year-old male who had come at our emergency department. He was a non-hypertensive, unknown medication since he never had any documents with him. not diabetic, presented with left-sided chest pain 2 hours prior to his hospital arrival. I reported having been woken up by the excruciating chest pain, which was of sudden onset, squeezing in nature, radiating to the lateral neck, shoulder, and upper arm, and also reported the pain is worsened with the minimal exertion like walking. However, reported no known alleviating factors. He reported associated fast breathing, no
Excuse
cough.
Solomon, if
at
you
that
would mind
moment.
raising your voice, we can't hear you that well. Just speaking a little louder.
Okay, I think my phone should be having an issue. My computer, however, if you can get me.
Yes, now you sound louder. Thank you.
All right, okay. So he had no cough, no fever at that moment. He reported no vomiting or dyspeptic complaints as such. He reported also having been alcohol use, but does not smoke cigarettes or use any other substance of abuse. No issue of trauma to the chest at that moment. While at emergency, on primary survey, our patient had a patent airway and he was able to talk. He was tachypnic, respiratory rate of 32 cycles per minute. His admission SpO2 was 94. His chest, however, was symmetrical with the bilateral air entry noted and normal percussion notes. So at that point, since he was having a fast rate of breathing, work of breathing was high, we decided to put him on oxygen therapy through nasal prongs. And that's when our SpO2 went to 99 to 100%. He had no, his BP, blood pressure at that point on admission was 80/40 with a sluggish capillary refill time of literally more than 3 seconds. However, he had a normal GVP, jugular venous pressure, and no edema at that moment. However, he also had some aspect of cold extremities. So we established 2 intravenous white ball lines, instituted IV fluids, normal saline, and at that point also we took the blood samples for CBC, D-dimers, lipid profile, and cardiac marker troponin. RBS was done and was as well taken, and we needed to rule out H. pylori serum antibodies. On assessing his disability, he was anxious, restless, reporting much pain. However, he was oriented in time, person, and place. His RBS was, that is glycemia, which was taken random, was at 5.4 millimoles per liter. So cause of his pain and being anxious, we brought in IV morphine. Also, we actually at this point, we also thought of our differential causes of chest pain. So we are compelled to give him some oral clopidogrel at 300 milligrams. We also gave microaspirin 300. Ranolazine was given. Atorvastatin was given at 40 milligrams. Then we also ran IV omeprazole and IV hydrocortisone. On further exposure, Actually, we are able to assess his abdomen was of normal fullness, soft and no palpable organomegaly. ECG was done, and I beg that you go down the admission ECG. Admission ECG is there. On evaluating this ECG, for the sake of maybe not preempting, our experts should be able to take us through at that juncture when they come on board. Okay, let's get back together. So hello.
Yes, Dr. Solomon, we can hear you.
Oh, thank you. So that was the ECG. So we reevaluated him after 30 minutes. And we can check down. At that point, he had improved respiratory rate, and SpO2 as well had improved to 100. There we are compelled also to taper down our oxygen. His blood pressure had remarkably also improved to 100/65. Pulse rate had also improved. Remember, he was bradycardic, so 44. Right now we had 46/50, and our capillary refill time had as well improved. So at this juncture, actually, we're also in touch with the physician who advised we do INR PT. So the sample was taken. However, after the 30 minutes of the above intervention, our patient still continue complaining of pain with a very minimal improvement in pain intensity. So the physician was updated, and he instructed we initiate the patient on tenecteplase, 40 milligrams, which was to run for 5 minutes. I think we're taking marked precaution here on the duration of infusing tenecteplase. At the same time, we reevaluated our patient ECG. So the other ECGs were recorded. And at this juncture, actually, we are compelled to do every 30 minutes evaluation. So we should also have, we should be able to see the serial ECGs that were done. And like I mentioned earlier on, our experts should be able to take us through the serial ECGs that we did. This, so at this point, we generated differentials where we are managing a patient with acute ischemic heart disease, STEMI, precisely with a first-degree AV block, and cardiogenic shock. So you also realize that maybe let's go back to the second ECG. That was after tenecteplase infusion. You can take us back. So there was a slight improvement. This was actually before our tenecteplase got fully infused. So immediately, yes, move to the next. Kindly move to the next. Yeah, no, go back. Previous, previous ECG. Yes, that one. So this was at this juncture, we realized there was the recurrence of the inversions. And at this point, we actually referred the patient to UHI for PCI. Next, actually of significance, that was the post-PCI EKG. And I insist our experts will actually take us through them at appropriate time. And move to the next. So when this patient reached UHI, PCI was done. And this was the feedback actually we got from the doctor who attended to our patient, Mr. HJ. He reported there was a right coronary artery complete occlusion. And while the patient was inpatient, was admitted post-procedure, he reported he had a case which he attributed to hyperacute stent thrombosis. However, they were he did some defib, and we achieved the sinus rhythm later on. He also stated that RCA was stented with the 2 stents. However, we could not get the maybe the is which were done post-stenting. This patient was discharged. This patient was discharged. And then we have a 1 year. Somebody is talking in the background. When he came back for review, that was literally after some 6 months or so. This is the recent ECG that we actually had. It's not actually 1 year, it should be 6 months. So I thank you for listening. That was how far we manage that patient. Thank you very much.
Thank you, Dr. Solomon, for that presentation and going through how you were able to manage your patient. The floor is now open for our viewers to be able to react to the presentation. Any questions or comments that you might have? While you're writing those down, I'm going to ask our panelists here to react to what they've just read, starting with Dr. Connie.
Thank you so much, Solomon. It was a pretty nice presentation, and we are glad the patient actually survived in Uganda. Maybe of concern, we find your patient was given clopidogrel, at the same time given cardiac arrest. Just for the general population, why did you people choose to give the 2 drugs at once?
In ischemic tendencies, we tend to have a double antiplatelet therapy, which was readily available. And that one, we always tend to, actually, because I can say maybe we would love to use one. but I insist in an event of maybe an ischemic tendency, we decided to use dual antiplatelet therapy, which will help us. That was easily available, actually. Thank you.
Okay, so along the way.
And maybe, sorry to disrupt.
Yes,
The
Solomon.
other one maybe would be the nitroglyceride. And unfortunately, our BP was a little bit low. If you saw initially 80/44, so we could not really put in that one. So, yeah.
Okay, so along the way, Dr. Mbabazi is going to take us through the pharmacological management. I don't think we should dwell so much on that part of the case, unless if someone else has a concern. I'll ask the moderator to take over.
Did you have any other comments?
Yes, thank you, doctor, for the presentation. My concern too is on the drugs. Just wondering why the hydrocortisone and also the IV omeprazole. Was it because you thought it could be pain due to PUD, or you thought the patient, yes, has MI, but could get stress ulcers? Thank you.
Thank you so much. I think because of the near factors we are giving the dual antiplatelet therapy, that was one of the reasons for the IV omeprazole too. The differentials maybe with suspected that should have also been maybe acute PUD exacerbation. That also gave us.
Can you increase your? I can't hear you, Dr. Solomon. You got kind of quiet.
Sorry. Can you hear me now?
Yes.
Okay. You realize to yes. Your prediction should have been right. Our differentials, one of which could have been maybe acute PUD exacerbation. So it also compelled us to think of giving IV omeprazole. The other argument would be we are giving high doses, the dual antiplatelets, that is the microaspirin and clopidogrel, and that one would in any case still worsen in case the patient had a PUD. So I think that compelled us. Hydrocortisone, this was, like I insisted, I was in touch with my physician who advocated for hydrocort, but also in preparation for lytic therapy, we tend to always give the hydrocortisone. Yeah.
Okay, thank you, Dr. Solomon. Dr. Mbabazi, I believe, has something to add as well. Go ahead, doctor. You are still muted, doctor.
Actually, I'm not muted. I hope
I can hear
you're able
you.
to get me.
Yes, I can hear you now.
Well, that's perfect. So I don't know how you want to run this, but I think I'm going to over-interrupt a lot. And I really, really request Dr. Solomon not to feel attacked by my comments, because this is a learning one. It is a learning platform. So what I would like to say is that first and foremost, if he goes back to how the patient presented, and I'm seeing most of these questions are coming up. Why did you give omeprazole? Why did you give hydrocortisone? It is just because that most of the time when a patient presents with chest pain, we don't know what to do. We don't know the diagnosis, and many people tend to give anything that they think about. The patient has come with chest pain, we think is asthmatic, give hydrocortisone. The patient has come with chest pain, we think it could be PUD, give omeprazole. And those are some of the mistakes that we make and delay the patient. And I think this is why this platform is very nice, and it is going to help us on how to approach a patient with chest pain. So the other comment that I really had was, if you look at how this patient presented, this is a very good case. First of all, it is an atypical case, because as you can see, it is a 41-year-old male who is presenting with acute chest pain. And traditionally, we tend to think that it is the older people who suffer from acute coronary syndrome. So, but this is a 41-year-old. Another thing that makes the case unique is that this is an Asian man. And I would like to inform the public that every time you get an Asian man with chest pain, please pay attention to that patient, because we know coronary artery disease is more prevalent in the Asians, and they tend to present younger than the African population. You could have ignored him. You could have ignored him thinking that acute coronary syndrome does not happen in the young. But being an Asian, please pay attention. Then the other thing that I would like to address is the many delays that happen to this patient. As you can see, the patient already presented with an EKG diagnosis of acute coronary syndrome. And we know that the guidelines say if a patient comes with chest pain, within 10 minutes, you should have an EKG. This one already had an EKG, but we went ahead to do an admission EKG. Was that really necessary? That is a delay. So after you have made a diagnosis within 10 minutes, we usually set time is muscle. The more you delay, the more myocardium you lose, and the poorer the outcomes of your patient. So we see that we delayed there because we know that when a patient comes with an acute coronary syndrome, within 120 minutes, that patient should be in the cath lab. And if you are unable to take the patient to cath lab, within 120 minutes, that patient should have received lytic therapy. But you can see the delays, right? And after the procedure, of course, I see, the decision really to think about lytic therapy and perfusion, it took a lot of time, which really increases the risk of poor prognosis for your patient. And when you look at your EKG, which we are going to go through, this was an inferior wall because the ST elevation is in the inferior leads. Then you start thinking about what complications can happen because of that. And some of the complications with inferior wall is bradycardia and third-degree AV block. You already see your patient had what? Had a bradycardia. That shows you that your patient is really, really unstable. And those are the patients that benefit from PCI. We waited. We don't know why the patient was bradycardic. We started giving IV fluids, and we were expecting this patient to improve, which is really wrong. So at that point, that is when the decision should have been made to lytic the patient because we had no cath lab, or transfer the patient to a center with a PCI. And I saw people asking about what is PCI. PCI is the gold standard of treatment of STEMI. Is percutaneous coronary intervention, means you go into cath lab, you identify the vessel which was blocked, then you unblock it basically. That is what PCI is, gold standard for the treatment of STEMI. Then the other thing I saw people asking, why do antiplatelet? According to the guidelines for the management of acute coronary syndrome, we don't give a patient monotherapy. Actually, we give dual antiplatelets, and on top of that, we also give them Clexaid, synergistic action, in the hope that maybe it will help us to open the vessel or prevent worsening infarction. At that moment, I will clear so that we can hear from other people.
Thank you, Dr. Mbabazi, for your comments. I think she's made a very good point about making sure that as we get patients like this, to make sure we're doing proper assessment and doing interventions based on what we get through our assessments, which we've covered multiple times through these echo sessions, is making sure we're going through our ABCs and treating accordingly. So thank you, Dr. Mbabazi. We are now going to move forward to a presentation by Dr. Kani on assessment and investigation of a patient with angina. Before we move on, I apologize. We're going to have one of our experts has joined us online. Dr. Asia, you can unmute and introduce yourself.
Hello, everyone. Thank you for the case presentation. Thank you, Dr. Mbabazi and other experts. I hope you can hear me clear.
Yes, yes, we can.
Okay, thank you, everyone. I'm Dr. Asia, emergency resident from Sudan, Khartoum.
Thank you. So Dr. Kani can now go ahead and do her talk.
Thank you, Bethel. So I'm going to talk about the assessment and investigations patient, you suspect to have an acute coronary syndrome or angina. But briefly, I'll talk about the epidemiology. According to a research by UHI and I think WHO, we find that 10% of the Ugandan population is actually having hypertension. And we've read that we have the modifiable factors, risk factors for acute coronary syndrome, and then the non-modifiable. So the non-modifiable are really your age, anyone who is way above 65, except for the exceptions Dr. Mbabazi has just given us. You are going to start thinking of acute coronary syndrome in someone who is going to present the way I'm going to go through it. It's more prevalent in the male population, but still you don't rule it out in the female. And then we've seen it more common in the Blacks, in the Asians. So those are the non-modifiable risk factors. And then, of course, on the other arm, we have the modifiable risk factors. We have hypertension, we have diabetes mellitus, we have smoking, we have hyperlipidemias. And if you look around our population, we are eating so much junk. So we're having a high number of people with hypertension. We have so many diabetics currently. We have very many people who are overweight and obese. So as a patient comes in with complaints of chest pain, which is acute on onset, look at these risk factors and do what we call a risk stratification. They'll help you try to put your differentials in order, and we minimize the time delays between presentation and intervention. So typically, this is a patient who is going to present to you. I'm going to try to break it down to the simplest form. I saw people complain about EKG, PCI, cath lab. So I'm going to try and make it as basic as possible, because these patients will reach us either in the health center 3, health center 2, or even in our private clinics. So you're going to have an adult patient. It could be a female, it could be a male, it could be a Black. You know, Uganda, we have very many races. So this patient is typically going to come to you and they will tell you, I've got this acute sudden chest pain that is tight in my chest. I feel like something is holding my chest tight. And this pain is typically in the left part of our chest. And the pain radiates to the same hand that's on the left. And it will also go up to the neck, and it may involve the jaw still on the left side. This pain is described as being retrosternal because you feel it's behind that breastbone, behind there. So we call it retrosternal. If someone comes with such a presentation, given their age, given their gender, given their sex, and other modifiable risk factors, I want us to start thinking of acute coronary syndrome as topping our differential diagnosis. However, we have what we call angina, where someone tells you, I got this severe crushing pain in my chest. It will be typical, radiating to the jaw, to the left hand, to the neck. But then when I took a rest, this pain is usually there when I'm walking, but when I sit down and take a rest, this pain actually goes away. So that's what we call angina. So you're going to hear words like STEMI and NSTEMI. STEMI is basically ST elevation myocardial infarction. And to break it down further, an infarction is death of muscle due to ischemia, due to the fact that that muscle wasn't receiving adequate oxygen. So you start with the ischemia, that's the angina bit, and then end up with infarction. That's the myocardial infarction. How do you tell that this is a STEMI or non-STEMI? It's really after you looking at the ECG. So we've got this patient of ours, and briefly, the people who have brought him or her in have told you that you're going to go to use the ABCD approach, the one we preach in emergency medicine, to assess your patient. Usually, if they have not yet collapsed, they'll be able to talk to you, they'll be able to explain how they feel. This patient may be diaphoretic, in a panic mode, because they feel that their heart is going. So if they can talk to you, it means their airway is patent. You're really not going to do much for it. But if they come already in shock and they cannot talk to you, you want to protect their airway. You're going to do the airway maneuvers, the head lift and the head tilt and chin lift. In case you suspect any trauma, you can do the jaw thrust, but you already do the head lift and the head tilt and chin lift. So after that, you're going to assess their breathing. You're going to take their respiratory rate. It's really going to be in the roof. They are going to be tachypneic because of all the anxiety and panic they are having. You want to, if you have a pulse oximeter, you want to do their SpO2s and supplement their oxygen if you have the oxygen. If your center doesn't have oxygen, don't say, I don't need to find out. Please find out how they are saturating. Listen to their chests for any crackles. Sometimes they have right-sided heart failure, so they may come in with pulmonary edema. So listen to that chest and just note down if they have any crackles or not. In your saturation, you're going to look at their capillary refill time. If it's greater than 3 seconds, in this we are trying to categorize whether they have cardiogenic shock or not. Remember, cardiogenic shock is going to kill them before you even proceed. So find out their capillary refill time, check their pulse rates, and usually they are tachycardic initially, and then they will proceed to becoming bradycardic. But also, in patients who have clots or right coronary artery block, usually they will present with bradycardia other than tachycardia. So you also want to know their blood pressures, still to categorize the type of shock they have. They will usually be hypotensive if they are in shock, if they are in cardiogenic shock. Look at their neck vessels. Are they very visible, even without too much exertion on them? It means these are patients who are having concurrent right heart failure. You want to do their GCS, that's the Glasgow Coma scale in the disability part. If they came in with cardiogenic shock, decompensated, they are most likely going to be unconscious. And at that point in time, you actually do not have time. Like Dr. Mbabazi told you, time is muscle, time is myocardium. So you want to do the basics we usually do, the random blood sugars, look at their pupils, and tell if you're not working with a dead body anyway. In exposure, you want to make sure they are not hyperthermic, because some hypothermia is actually good for patients who are probably arrested due to cardiogenic shock, due to acute coronary syndrome. So after that quick assessment, at that point in time, you want to run through your sample. Dr. Solomon really highlighted it so nicely, and in the sample history, that's the point where you're going to tell, were they exerting, were they exercising at the time they got the pain, were they resting at the time they got the pain, because it's going to help you categorize whether it's a stable angina or an unstable angina. And after that, after you having a differential of an acute coronary syndrome, you need to have an ECG done. That's an electrocardiomyography. It's the same as EKG. It's not different. You need to have it done within 10 minutes. Someone is going to ask me, what of centers without ECGs? Yes, that's where your clinical assessment comes in, and you're going to start this patient on lytic therapy that Dr. Mbabazi is going to take us through, so I'm not going to dwell so much on that. After starting your therapy, you're going to now do the further investigations. That's, you've done your 10 minutes ECG. The moment the patient comes in, you're going to take off blood for troponin. Troponin is a cardiac marker. It's released due to cardiac ischemia and infarction, and you'll find it raised. Different labs will give you a different normal range, so I'm not going to dwell on the normal ranges, but these are things that would come with the lab results. And it's advisable, if you're retaining the patient, to repeat the troponin levels at least 3 to 6 hours after the first level. If you have access to an echocardiograph, you need to do one to rule out any new onset motion wall abnormalities. But these, I am sure, not most of us will do. The gold standard would be a coronary angiograph. Of course, this is going to really show us where the block is, and this is usually done at the Heart Institute as part of the PCI, I think. You also want to rule out any other possible causes of chest pain. We've seen patients with PUD may present the same way, but there are differentials. There are things that will tell that this is not a this is not a coronary syndrome, and this is not a PUD. But you want to take off those samples just to make sure you've eliminated them too. But the clinical presentation and your quick assessment should be able to tell you that this is acute coronary syndrome. Something that I didn't comment on earlier on, in the diabetic patients, sometimes they may not present typically with that typical crushing chest pain. They may have vague symptoms such as abdominal pain. So you also keep it at the back of your mind. That includes that includes women. They may also not present with the typical symptoms. They may have really abdominal pain that is very vague. They may tell you, I just feel not myself. So given the risk factors, have it at the back of your mind. Thank you. I think that's what I had for us in brief.
Thank you, Dr. Kani, for such a good presentation on assessment of patients with angina. Like she's reiterated, and Dr. Mbabazi have reiterated, making sure that we are doing our ABCDEs to determine what's life-threatening to your patient. And so this goes for providers that are in clinics that may not have access to ECGs or cath labs, that you're able to quickly assess your patient, figure out what's going on so that you can move them to the appropriate facility. So as we go, it looks like Dr. Mbabazi has something she'd like to add, and then we'll have the next presentation. Please keep your questions in the chat. They will be answered at the end. Thank you.
Oh, thank you very much for wonderful presentations. Please, you'll forgive me, I have to keep interrupting. Number one, a point of correction is that most of the time we tend to think that the word is angina, but the correct pronunciation actually is angina. And another other thing that I wanted to clarify is that even that if you see like the setup of Uganda, the health worker that the patient interacts with first is the emergency medicine system in Uganda. Or they usually tell us that the person who has seen the patient first is the emergency room, because we don't have so many emergency rooms in Uganda. So the person who sees the patient first, there is a very big role in whether that patient will survive or not. And that is why I like this session very much. So the way you approach a patient who you're suspecting to have an acute MI in the emergency room should be different from the way you approach other patients. You're not going to go through all the steps, because the more time you waste, the more muscle you lose. So when the patient comes to you and they have chest pain, actually we don't even say chest pain, they say any pain that is from the eyeball up to the navel. That is acute coronary syndrome until proven otherwise. So if a patient comes to you with pain from the eye to the abdomen, number one, you have to rule out acute coronary syndrome before you do anything else. And another point you have to note is that no matter how smart you are, the diagnosis of ST elevation MI can only be made on EKG. Without EKG, you're just limited to angina. But if you have EKG, then you make a diagnosis of STEMI. The moment your diagnosis is STEMI, you drop anything else you're doing, and your mind should shift to, how do I reperfuse this patient? So in a setting of ST elevation MI, taking off bloods is not useful. A troponin at that point is not useful. INR that was done, CBC's renal functions, all those things which waste time, we don't dwell on them, including echo. What we are focusing on is how much time can we intervene? What's the time between patient presentation and intervention? So what we are saying, please don't waste time on unnecessary examination of the patient, unnecessary history. The moment you have an EKG diagnosis, please, your next step should be, can I transport this patient to a center that can take the patient to CAR within 120 minutes, which is 2 hours? And if I can't do that, can I give the patient lytic therapy? So the moment after this session, what we want people to do is, can your hospital get access to lytic therapy? That is going to be the most important thing. Because we know all the cath labs in Uganda at the moment are concentrated in Kampala. We have about 4 of them. Outside Kampala, we don't have a cath lab. What is going to save us? Lytic therapy. So the people who are here, if you are DHO, you are a medical soup, you are the head of your unit, can you agitate NMS to give you at least an ampule of lytic therapy? Because that is what is going to save your patient. So from today, what you need an EKG machine. Then an EKG machine is not enough. You need to know how to interpret the EKG. And what other people are doing, actually, they are taking our numbers. When they get a patient with chest pain, they do the EKG, they send it to us, we interpret immediately and tell them that this is a STEMI or this is not a STEMI. So, and the other thing which I liked about the emergency doctor physician who was teaching us, she talked about that not all patients with acute coronary syndrome are going to present with chest pain. Please note that we have what we call angina equivalents, especially, as she said, patients who are diabetic. Remember, they have neuropathy. They don't feel pain. So you don't expect a diabetic to come to you with chest pain. We have women and we have the elderly. For them, they tend to present differently, which we call angina equivalent. So watch out for patients who tell you shortness of breath, patients who tell you, doctor, these days I don't feel myself, and they have risk factors, or patients who come to you with vague symptoms. Even those patients think about acute coronary syndrome. But what I really wanted to stress is, don't waste time doing unnecessary clerkship and unnecessary examination when you have made a diagnosis of STEMI. EKG within 10 minutes, we can't stress it any further, and lytic therapy should be given within 120 minutes of you being in contact with the patient. Thank you. And another thing is that you need to pay attention to how long has the chest pain been. Please, if a patient presents to you after 24 hours with chest pain, don't give them lytic therapy because it won't benefit them. The maximum benefit will be felt within 120 minutes from the time of chest pain, and it can be stretched up to 24 hours. Then for lytic therapy, beyond 6 hours, the dangers or the risks outweigh the benefits. So please, and that's why we're saying that please sending to us a patient you have kept in the clinic for 2 days, 3 days, or 4 days, you're not helping the patient. If the patient presents to you, kindly refer them to a center that can handle them. Thank you very much.
Thank you, Dr. Mbabazi. Again, time is muscle, so let's make sure we're moving quickly. Keep putting your questions in the chat. We will answer them after. Right now, we're going to go to our critical care nurse expert, Ms. Samali. Did I say that right?
Yes.
Samali. She will be talking about nursing care for a patient with myocardial infarction. And just as a reminder, Dr. Asia is in the group chat as well to answer any questions that you might have, but I'm also keeping track so that the experts can answer them at the end.
Thomas. Move the camera to her.
Hello, good afternoon, everyone. Samar is my name. We are going to go through the nursing care of a patient with myocardial infarction, and I'm going to dwell so much on a tertiary center like Heart Institute where I work. As my slides are coming up, some of these patients who have myocardial infarction may be referred, like the one doctor sent from Ginger. Others are walk-in patients who got the chest pain in the night and then they self-refer themselves to Heart Institute. So we are going to be looking at any patient who comes in Heart Institute and has myocardial infarction. Slides are coming up, just hold on a bit. So when our patients walk into Heart Institute or are brought in by ambulance services, whatever it is, we do triaging. It's very important, triaging. Like the set of Heart Institute right now, all the patients who come in, whether they've come for consultation, ECG, echo, we do triaging. In triaging, we are able to pick up those patients who are not so well to follow the normal routines. So when we do triaging, we ask those patients who really are not feeling well, sometimes even without asking. We are walking through those patients, we can see that somebody is sweating, somebody has severe pain, so we pick them up quickly so that they do not follow the normal routine, because we have that at the back of our minds, that time is muscle, so we know that some patients walking with myocardial infarction, we want to save them as quickly as possible. When we do triaging and we have those findings which doctors just talked about, which are pointing to myocardial infarction, as nurses, we quickly run the ECG. This is not something that requires for us to wait for the doctor to order it. And on ECG, we do a 12-lead ECG. There are many facilities which have ECGs around, but I've seen some patients walking in with an ECG which only shows the rhythm strip. You may not pick so much with that ECG. So we do a 12-lead ECG where we can look at all the leads which are looking at the heart. And once the ECG is done and it is pointing to myocardial infarction, we quickly alert the emergency response team. Meanwhile, we are moving the patients to the emergency area. This patient has to be kept on complete bed rest. I just take an example of a patient who came from home. They took a taxi, they came in walking. After ECG, you see ST elevation or something that points to MI, and you are telling the patient, you know what, you are not supposed to walk. You can't go to the toilet, you are going to do everything from here. From the practical point of it, many patients resist. They tell you I walked from home. How come you are telling me that you are putting me in a wheelchair? We quickly explain that from what we found out on the test we've done, it's risky for you to walk. So we have to put you on a wheelchair, and that's what we do. We move them to the emergency treatment area. We alert the emergency response team that involves the cath lab and take all other staff who work in the cath lab. We have to record the baseline vital parameters. It is very important, much as we had done in triage area, but even here we have to repeat. That's when we will see somebody who is bradycardic, somebody's SpO2, somebody's blood pressure, any hemodynamic instabilities, we have to capture them and we know our beginning point. At this point, we have to initiate emergency treatment while we are still in the emergency area. Some of the emergency treatment we are going to give is oxygen, but we only give oxygen supplementation if the SATs are below 91. We give the dual antiplatelet therapy, which has been talked about. Aspirin. On the note of aspirin, please note that we don't give the coated aspirin, which is going to take a lot of time to cause the effect. We give the normal aspirin, 300 milligrams, and it is chewed, not swallowed. It is chewed such that the effect picks up quickly, because by the time it gets to the stomach, mechanical breakdown has already been done in the mouth. So please take note of that. If the BPs allow, we give sublingual nitroglycerin, which may be in a form of spray or tablets, and put under the tongue, not swallowed. We can give IV morphine to relieve pain and also to allay anxiety, because like the doctor said, this kind of pain causes a lot of panic. Patients are very anxious, so we need to allay their anxiety. We put IV normal saline. It could be to support the hemodynamics, maybe the BP is low, but importantly, we need it to hydrate the kidneys in preparation for contrast introduction in cath lab. Please. Okay, so the previous slide just talked about the treatment, so it's not like in order of occurrence. So we have to obtain an IV access, and we don't use the small gauge cannulas. We need large bore cannulas too, if possible. And at that time of putting the cannula, we need to draw blood samples, as mentioned in the slides. But please take note that we do not wait for these results to come back to intervene or to take the patient to cath lab. But they are needed. The results can find the patient in cath lab, or sometimes if it's too hard for you to take off the sample, as we take the patient to cath lab, we inform them, and when they do the first access, they take off the sample. Especially, for instance, the CBC, in the case the patient bleeds, we need to know where we started from. The renal function, the doctor may be interested in knowing the creatinine clearance, serologies, HIV, hepatitis, you know very well, grouping and cross-matching, just in case we need to transfuse this patient. We have to do skin preparation still, and that will involve shaving the groin area. Access, some people, doctors use different accesses, but for this matter, we need the groin area, and it has to be shaved. After that, we have to move the patient to the cath lab. I think I missed something in the after triage, because the slides were not yet displayed. After putting the patient on complete bed rest, we have to do a very quick and detailed assessment. This is not the usual nursing assessment we do where we ask questions, how many sexual partners, blah, blah. This one is very detailed and on point. And because this is not a one-nurse show, it's not like you sit down and do the assessment, then you do this and that. We are being very conscious of time. You are doing this, your colleague is doing the other. And we have to do patient and family counseling. Very, very important. Much as this is an emergency, we don't just rush the patient to cath lab without them knowing what's the problem, what is going to be done. So we have to inform the patient what our findings are, where are we taking the patient, what are we going to do, and we must obtain their informed written consent. So I had skipped that, and it's very important. So after moving the patient to cath lab, After moving the patient to cath lab, I won't talk so much on what happens there. I don't know whether it will appear in Dr. Happy's slides, but nursing care continues, but I won't take you into that. After PCI has been done, the patient is not sent home. We really need to keep this patient with us for some time as we do a lot of things. And one of the things we are going to do is monitoring. We are going to monitor several things. I'm being focused here for that matter. So we are going to keep this patient in a flat position. Very, very important to explain to the patient why we keep them in this position for 6 hours. I'm counting the 6 hours if the introducer sheath was taken out from cath lab. But if the patient came with it to CCU, the 6 hours will be counted from the time the sheath is out. It's very important to explain to the patient the need of maintaining this position. Many times patients are stubborn, they want to get up, they want to do this and the other, so they need a lot of explanation. Lying on the back sometimes is disturbing to many people, especially those who have back issues. We can allow the patient to slightly turn on the side, but not lying on the leg where the procedure was done. Okay, the access was made, and also keeping that same leg straight. They can flex the other leg, but the one where the access was obtained, it is not flexed until the sheath is out. Then when she's out, we count the 6 hours. We have to connect this patient on continuous ECG monitoring. This is very important because we will be able to know if the patient is getting a reinfarction. You start seeing again the ECG changes, which are pointing to the fact that patients are getting another infarction. Patients tend to get life-threatening arrhythmias that even after you correcting the problem in a cath, again, an arrhythmia can kill the patient. So it's important we keep them around us and monitor them. Usual vital parameters, BP, heart rate, SpO2, all those are very important to be monitored and recorded and reported. It's not just a matter of monitoring and you keep quiet. When you monitor, you record, and again report anything you see is out of range. We do serial ECGs 6 hourly for that matter, because sometimes these patients can get a reinfarction in the same area or in a different area. We have to monitor for bleeding. This bleeding can be at the puncture site. It may be obvious and you will see blood coming out, or it can be concealed and it appears in a form of a hematoma. So we normally caution our patients that we are going to be continuously opening. Because if you don't tell them, you keep opening a patient, they scream, "Why are you opening me?" So we inform them that we are going to be monitoring for any bleeding. And we normally tell them, we teach them how to touch down their thighs, and inform them if you feel anything like liquid on your hands, something warm, you quickly call us, or you send your attendants to call us. But normally we are around and we continuously monitor. Bleeding has happened. Sometimes you first see the blood pressure is dropping, the pulse is going up, you are wondering what it is, yet the patient is bleeding. So it is very, very important to monitor. We do cardiac markers serially also. Doctors talked about it. We have to keep a trend on them. We do ACT, that is activated clotting time, because in case the patient came with they did a stenting, they normally come to CCU with the introducer sheath. So before we take it out, we must be having an ACT which is below 150. We continue drug administration. We give analgesia, we give the dual antiplatelet therapy, we give the statins, antibiotics, and any other drugs as they may be prescribed. So for the sheath removal, like I said, we monitor ACT until it is below 150. That's when we can remove the sheath. Removal of the sheath, I didn't put anything in the slides. It's also a tricky thing, and we have to be very careful when we are doing it. Sometimes patients collapse as we are taking out the sheath. because of the pain. Because when we take it out, we have to place a lot, to apply a lot of pressure. This is the main vessel which was punctured. We tend to apply a lot of pressure. So if you don't take the precautions, for instance, we infiltrate lignocaine around the site, we warn the patient on what to explain, we are continuously monitoring the patient is still on ECG monitoring. If we don't do all those, you can have a patient who had a nice PCI, and again they die because of a collapse when you are taking out the sheath. Assuming our patient did well, everything went on well, sheath has been removed, there is no bleeding, and normally they don't take so much time in the hospital. 1 or 2 days, they will be going home. It is very important to give them some advice as they are going home, and one of them is rest. We caution about certain activities like going to the garden, driving, lifting heavy things, engaging in sexual activities, especially for the first 2 weeks, because when we take out the sheath, there is a blood clot which forms there to block off the entry point, and it was a very big blood vessel. So if they engage in such activities before 2 weeks, that clot may break away. It can either go in or go out and the patient bleeds. So we caution them. And from experience, after the problem has been corrected, pain is gone, patients don't feel like they need all that time. And the biggest question they normally ask is about sex. I don't know why. Among all those activities I've listed there, patients don't ask about them, but they put you aside and ask, for how long can I wait until I can have sex? It is very important. I don't know why. But we have to caution them that if they do it so early, they may get other problems. They have to hold on a bit. Adherence to the prescribed treatment regimens is very important. I know Dr. Happy will talk about it. The drugs they have to continue taking even after PCI has been done, because it's not the end of it. It is important to adhere to any prescribed treatment regimens. I'm not talking about taking tablets alone. Others could be rest and any other thing doctor prescribes. Regular clinical reviews are very important. Sometimes patients think the problem has been sorted. I don't need to go back to the cardiologist. It is still very important because I hope Dr. Happy will talk about it. Patients develop complications of myocardial infarction even after PCI has been done. And during the regular clinical reviews, these can be picked up before they cause problems. Risk control and management, very important. In the assessment, I said we do a quick and focused one. After the problem has been sorted, we need to do a thorough assessment into the risks that could have predisposed to the MI. So once they've been picked, it is very important that you talk about them with the patient so that we have prevent further attacks happening. Some of those risks include cigarette smoking. If somebody has been a smoker, encourage them to quit in a healthy way. Encourage patients to have their blood pressures controlled, their blood sugars controlled if they are diabetics. If they are taking statins for the dyslipidemia, let them take them well and monitor them. If a patient is obese, they need to be guided well on which ways they can control their weight. Of course, this is not somebody who is going to go on the road and run to control weight, but they need to be guided on the diet and other physical activities they can do comfortably and safely in order to control their weight. Stress management, a bit tricky. Sometimes you are busy telling somebody to control stress when yourself you can't control it. So we have to be keen on this to help our patients to manage their stress. For women in particular, we should caution them on the use of combined oral contraceptives because they put an added risk to them developing another myocardial infarction. Thank you very much for listening.
Thank you, Nurse Emily. I really think she did a really good job of going through treatment and management as nurse care in a facility. I see your questions in the chat, and it looks like Dr. Mbabazi and Dr. Asia are answering a few of them. Again, we'll go over these at the end due to time. We'll make sure Dr. Mbabazi then goes ahead and does her presentation, and then we'll take questions after her presentation. Thank you.
Yes, hello. I missed it.
Dr. Mbabazi, try speaking one more time to make sure we can hear you.
So I'm wondering whether you were talking to me because I missed it.
Oh, you missed it. Oh, I was saying,
It's time for me to present.
yes, we're gonna have you present and then we'll do questions after.
Okay, I would love my presentation to be projected because when I put it on the phone, some of the files are too heavy. Then the other issue is that my computer has an audio thing, so it would be very helpful if you could help me project.
Okay, I will let the technical team know that. Did you send the slides to the technical team here, Dr. Mbabazi?
Maybe just try, maybe you allow me to share, but that means that one of the videos I wanted to show you, I won't be able to show it.
Okay.
Allow me to share the screen.
Yeah, you can project on your screen, but then we can do it here as well.
You have disabled me from sharing.
Oh, let's fix that. I think you can now share. Are you able to do that? Still saying no? Dr. Mbabazi, are you able to share now?
You have really blocked me from sharing.
No, we're working on that. It's been fixed. Try it again.
Okay. It's okay now.
Yes.
So I intend to really show a few slides because I was advised actually not to to project any slides, but we can proceed. And what I wanted to share with members is that
amazing class.
what I wanted to share with members is that we really have to be cognizant of the fact that not every chest pain is equal to acute coronary syndrome. So in cardiology, we have what we call the big four causes of chest pain. And one of them is what we are discussing today. acute coronary syndrome, which for the purpose of this presentation, we called it angina or chest pain. Then the other important thing you have to look out for is aortic dissection. And the reason why we want you to pay attention to aortic dissection is, remember, just imagine if someone comes with a dissected aorta and you mistake it to be acute coronary syndrome, and you go ahead and give them lytic therapy, what would happen to that patient? Of course, that patient would bleed to death. So before you say that this is an acute coronary syndrome, you really have to be sure that it is, and you have to be sure that it's not an aortic dissection. And how do you distinguish the two? Of course, the character of the chest pain. And that is why I wanted us to really talk about what is angina and what is not angina. So when we talk about chest pain of acute coronary syndrome, typically we say that this is a patient with risk factors or comorbidities. In the typical presentation, it's usually a middle-aged man, but this time we saw that our patient was young, and for him, his risk factor was the race. So it is a middle-aged man most of the time, or it could be, and when it is elderly, both sexes are involved. This is a patient who either has a family history of coronary artery disease, or this is a patient who has been hypertensive for some time, the patient diabetic, or they are smoking, or they are dyslipidemic. So this is the patient, when this kind of patient presents to you with chest pain, and you want to know, is this angina? What helps you know? And one of the things is, if a patient is having unstable angina, is the character of the chest pain. Most of the time, a patient will tell you that, doctor, I feel as if I have a heaviness in the chest. I feel as if a stone is seated on my chest. If they don't say that, then they will tell you that, doctor, I feel as if my chest is tight. And if they don't say that, they will tell you that, doctor, I feel as if something is constricting my chest. And when a patient says that, then you automatically should be able to think that that is the typical character of chest pain associated with myocardial infarction or acute coronary syndrome. Then after they have told you that, you want to ask them, for how long has this chest pain been? Typically, the chest pain of acute MI lasts for more than 20 minutes. It doesn't go away. It lasts for more than 20 minutes, and sometimes it radiates. And the chest pain of angina radiates. It can radiate to both arms. And what helps you know that this is angina is that it will radiate to the medial aspect of the arm. The chest pain which radiates to the inner arms most of the time is not angina. Then the other thing is that it can go to the jaws, and as we had already seen, that pain can go to the eyeballs, and also that pain can go to the stomach. And that is why most of the time you find that most patients with acute coronary syndrome have been treated for PUD for many days before they deteriorate and are referred to a cardiologist. So that is one of the things that I thought that we may look out to, and that is why they say sometimes that pain can come as burning, which we might term as indigestion. So the other peculiar presentation that I would like members to pay attention to is that your patient may not come with chest pain, but the initial presentation, they may present with a complication of acute MI. So in the recent past, I received a patient who presented with ventricular tachycardia. And when I admitted them on the ward, I was very that this is ventricular tachycardia, very unstable. When I went ahead and shocked the patient into sinus rhythm, that is when I was able to discover that now the EKG switched from a ventricular tachycardia ECG to a STEMI ECG. What does that tell us? That the patient was presenting to us with a complication of MI. So meaning that without an EKG, we would have missed that diagnosis. Then the other complication that the patient can present with is heart failure. Your patient will be in intractable heart failure and you don't know what's going on until you have done the ECG. Then the other common thing, especially which I've liked about Dr. Solomon's case, is this patient presented with bradycardia. And we know that one of the causes of bradycardia or third-degree AV block is an inferior wall myocardial infarction. Some patients can even come to you with VSD. So really with the acute coronary syndrome, you have to keep your mind open. High index of suspicion is the way to go. Then of course, and the other things we had talked about is the things we call angina equivalents. No chest pain, but the patient has shortness of breath, easy fatigability, feeling blur. All those things will happen in the category of patients that we have talked about. Then just to clear some confusion in the chat, when we talk about acute coronary syndromes, these were past known as, you could say, myocardial infarctions, but now we call it acute coronary syndromes. Every time a disease is described as a syndrome, it means there is no specific thing that can define it. You need so many things for you to arrive at the diagnosis. So when we say acute coronary syndrome, what do we have? Acute coronary syndrome has 3 components. We have unstable angina, and we want you to know what makes this patient unstable angina, why do we say this patient is ST elevation MI, or what makes us say that this patient is non-ST elevation MI, which we usually call NSTEMI. So if a patient comes to you with chest pain, we make those categorizations in the patient because what the patient has determines how fast you're going to intervene. If a patient comes with a STEMI, I'm going to intervene immediately. If a patient comes with a non-ST elevation MI, then I'm going to score them to determine should I intervene immediately or this patient is not very urgent as the one who has come with ST elevation MI. So you do your ECG. After you have done your ECG and there is ST elevation MI, that is a very sick patient. You don't need to do anything else. But if you get a patient with chest pain and you do an EKG, and an EKG just has ST depression or T-wave changes, there are so many things which can cause ST depression or T-wave changes on the EKG. Then you want to ask yourself, are the causes of these findings due to a myocardial infarction or not? And at that point, what is going to save you is that you're going to do biomarkers for this case, which is troponin. Please note, we don't do biomarkers for STEMI, but we do biomarkers for a patient who has presented with what we think is non-ST elevation MI. So you have done your EKG and you have confirmed there are no features suggestive of ST elevation, but you have found either ST depression or T-wave inversion. You want to know, is this a myocardial infarction? How do you confirm that? That requires that you're going to do a troponin. And if you do a troponin and you find it's raised, then you're going to confirm that this patient has a myocardial infarction, but this time it is non-ST elevation myocardial infarction. Then the other component of the syndrome, because we have said there are 3, then the third one is unstable angina. And with unstable angina, the difference between it with an NSTEMI is that you're going to have STT changes, but however, the troponin is going to be normal. So I hope that has been clear. But in your head, you know that what carries a high mortality and high morbidity is the ST elevation MI. And please note that I've not said that the NSTEMIs don't die or they progress well. They also do, depending on the scores that you employ and decide who should be worked on first or not. Then proceeding to the next slide. What I wanted to show on this slide is that when you get a patient with chest pain, there are so many causes of chest pain. Not all chest pain is due to cardiovascular disease, or not all chest pain is due to myocardial infarction. How do you rule out, or how do you know that this pain is not coming from the who has chest pain and has what we call a pointing pointing sign, most syndrome here. Most likely that is not acute coronary syndrome because the pain red and vague, and the patient is unable to point at it. Another patient says uses a fist to show you where the pain is because the pain is big. It is not by pointing. Most of the time, patients who point or it is bronchopneumonia or it is a pulmonary embolism. Then if a patient comes to you with that pointing sign, then be assured syndrome. How about if you have a patient and a patient who has a pointing sign and has a normal EKG, really you don't have to go ahead and subject them to a troponin because most likely it's going to be negative. But how about a patient who comes to you with chest pain, which is the second image, and they have sub-STT changes on the EKG? So that patient, that's the patient you should do a troponin on, or what we call biomarker. And if you do a troponin on such a patient and it's negative, then of course you have ruled out myocardial infarction and you start thinking about other cardiac causes of chest pain. How about the one who comes with a very big chest pain, like the way you see in this image, image number 3, with STT changes? So the major thing you're going to do is to distinguish between N-STEMI from STEMI. If your troponin is, if you have STT changes and your troponin is positive, that is N-STEMI. If you have ST elevation, as we had already seen, there is no point in doing markers because we know that even if you do them, they will be positive. Then how about a patient who, other patients with STEMI, please know that they will come in shock and they will, some of them will present with cardiac arrest. That is why they have said, if your patient is in cardiac arrest, is in shock with ST elevation, that is another presentation, then you confirm that that patient has STEMI. So if we go to the management, what we have been discussing, and I think maybe we should focus some time on this. As you notice in the developed world, if a patient gets chest pain at home, they are going to call their ambulance system or the emergency system, which we don't have in Uganda. So meaning if a patient gets chest pain, they are going to transport themselves to the hospital. So imagine you're stuck in Katakuya in your home, you have developed chest pain, in the middle of the night, there's no border, there's no taxi to take you to the hospital. At that moment, you already see that there is a delay. So in our setup, if you get an MI, the nature of our country is already against your survival. Most likely, you're going to have a poor prognosis because you're going to reach the hospital late because we are missing out on the emergency services. So
Did it pause?
No, it's unmuted.
Oh, okay. Dr. Mbabazi, I think we've lost you. So far, such a good presentation. Keeping your, sending your reactions into the chat and your questions as well. I see people asking about CPD links. Those will be given at the very end. Don't worry about it. Let's focus on the session. As we try to reconnect with Dr. Mbabazi, please keep adding your questions into the chat. Okay, it looks like she's back on.
I'm just, yeah, I'm back. The challenge is that my computer's audio is bad. Every time someone tries to call me, I lose my connection. So we are saying that now the patient has come to you, has already, we've been interfacing with the patient within 10 minutes. You have your EKG, and we have said doing an EKG alone is not enough. You should be able to interpret it. And when you interpret it, after interpreting it and you find it is a STEMI, happens. So we want you to think at that moment, now we are going into management. In acute coronary syndrome, we talk about reperfusion, because STEMI means that the supply to the blood vessels supplying the heart has been blocked, so we don't have perfusion. So now we are thinking about reperfusion. How do we reperfuse the patient? And we are
Excuse me,
saying,
Dr. Mbabazi, I'm sorry for interrupting. We
Slides.
can't see your slides.
No slides.
you don't see,
No, we cannot see
Yeah,
your
we are not
slides.
seeing the slides.
so I have to reshare again. Okay.
Yes, thank you.
Allow me to share. That should be okay, right?
Yes,
Yes, it's okay. We are now seeing.
Oh, thank you very much. So what was intervened? So we're saying that now that you have made a diagnosis that this patient has an ST elevation MR, we are going to think about reperfusion. And when when a patient, you have diagnosed that the patient has STEMI, then you ask yourself, even before you ask yourself,
we've already reiterated it. We're waiting to, Dr. Mbabazi, I think her network has messed up. Please just keep adding your questions into the chat as we try to reconnect with her.
I see a hand up. I don't know whether we should address it or not.
Okay.
Yes, Gilead, you can ask as I try to get my slides back. I think my
Okay.
internet has a problem.
Gillian Park, I see you raised your hand. You can go ahead and make your comment. Gillian, you've been unmuted to be able to say what you wanted to say. Okay. It looks
Okay, I
like,
think we just go ahead.
yes. It looks like Dr. Mbabazi is back on and the slides are on, so we're going to continue with the presentation.
So we're saying that when you receive the patient, you give them low molecular weight heparin, and if you use 1 milligram per kg, then you're going to give a BD dose. If you give 1.5 milligrams per kg, you're going to give it as once a day, but would prefer that you give 1 milligram per kg twice a day. Then the other thing that we are going to talk about, the other thing that we are going to give is the dual antiplatelet therapy. And the reason why we use dual antiplatelet therapy is for synergy. And this time in myocardial infarction, we don't give small doses. So we request that when you get a patient with acute coronary syndrome, even if you're not going to intervene, even if you're not going to give lytic therapy, at least the third option is going to be, you're going to give your patient low molecular weight heparin, and on top of that, you're going to give your patient dual antiplatelet therapy. And in the dual antiplatelet therapy, of course, we have aspirin, and this aspirin we are going to give between 300 and 600 milligrams as a loading dose. Then we maintain the patient on 75 milligrams. So the other category of drugs we are going to use is that the category which has clopidogrel, prasugrel, and ticagrel. The drug of choice would be ticagrel, but it's very expensive and very limited. But clopidogrel should be readily available. And you're also going to load it in 300 milligrams as a start dose, and you maintain the patient on 25 milligrams. So for centers which have access to lytic therapy, at the moment, the thrombolytics we have on the market in Uganda, we have tenecteplase, which would be our preferred option. Then the other thing that we have, tenecteplase is very expensive, and it is clot specific. That is why we like it, and it does not cause hypersensitivity to the patient, meaning that if your patient reinfected again, then you would have liberty to give them a second dose of tenecteplase. So, and since it is expensive and not readily available, our second option on the market in Uganda is streptokinase. So if you have streptokinase, you also give. And I had someone asking about how do you give tenecteplase. Tenecteplase is given as an IV bolus, whereas streptokinase is given as an infusion, and that is why some of the advantages that favor tenecteplase over streptokinase. So, and we are saying, in how long do you give tenecteplase, or when do we give lytic therapy? We are saying you have received your patient, you have given them pre-medication, which I have talked about. Low molecular heparin and dual antiplatelet therapy is pre-medication in preparation for primary PCI. Then if you are in a center, like most of our centers that we are in, we are very sure that this patient is not going to get to a center with a cath lab within 120 minutes, which is 2 hours. We are very sure of that. There's no question about that. Then this patient should receive lytic therapy within 2 hours. And research has really shown that for patients who receive lytic therapy within 2 hours, their outcome is as good as a patient who has received cath or who has received primary PCI. So if you can do that, that is very good. But what you have to note is that when you've given your patient lytic therapy, it still leaves the patient with a risk of rethrombosis. So what lytic therapy does, it buys you time or it saves the patient's muscle, improves outcome as you prepare to transfer such a patient to a center with a cath lab, meaning that if you give a patient lytic therapy, then their intervention can be prolonged and done within the next 12 to 24 hours. And that is why I wanted to tell you that when we are reperfusing the patient, we have 3 strategies. Strategy number 1, which is in the ideal setting, you have received a patient within 2 hours, or within ideally 2 hours, but can be stretched to 12 hours. Then you are in the ideal setting. Our strategy for intervention or for treating this patient is going to be what we call primary percutaneous coronary intervention. Please note primary. The intervention is primary because that is what you're going to do first. If you have a patient who has presented early, like this young man who came in 2 hours, then our option for reperfusion would have been primary percutaneous intervention. So that patient would have been taken to cath lab, a coronary angiogram would have been done, and the primary coronary intervention, basically what we are saying is that the blocked vessel would have been reopened and stented to reperfuse the tissue. So that is option number 1. Option number 2 is if I receive a patient and there's no cath lab within 2 hours, what can I do to save that patient? And that is what we call pharmacoinvasive strategy, which means I'm going to give lytic therapy, which is the pharmaco. Then after that, I'm going to send the patient to a cath lab center, which is invasive procedure. And that is why they call it pharmacoinvasive. So if you get your patient in your peripheral health care and you have lytic therapy, you give that patient lytic therapy, then within 12, you buy 12 hours in which that patient can now be transported to a center with a cath lab. We call that pharmacoinvasive. But what we are saying is that there are some patients whom you're going to give that approach of lytic therapy, then you proceed to cath. Sometimes that doesn't work. And the question is, when do I know that my lytic therapy has worked in this patient? There are some things we look at, and some of the major thing we look at is if your patient has come with chest pain and you've given them lytic therapy, has the patient's chest pain markedly reduced or has it completely disappeared? If that happens, then we tick and say lytic therapy has worked. Then the other thing we look at are the EKG changes. For example, if we look at the patient's degree of ST elevation, has it decreased by 50% within 1 hour? If that happens, then we say lytic therapy has worked. But for the patients in which lytic therapy has not worked, then we call that those patients, instead of getting primary PCI, we call it rescue PCI because they have failed on lytic therapy and now you have to transport them to the cath lab with immediate effect. So after you have reperfused your patient, please note that in this patient of ours, after reperfusing, the patient developed ST elevation again. So ask yourself why. That is the reason why we give dual antiplatelet therapy so that the stent which you have put in your patient to keep the vessel open does not occlude. So most likely in this patient, Dr. Solomon's patient, the patient did not swallow dual antiplatelet therapy. And because of that, the patient rethrombosed and the STs went up again. So that is why you have to be keen and make sure that your patient whom you have taken to the cath lab, you have to continuously monitor them and make sure that they have taken dual antiplatelet therapy. Then I know the next question would be, doctor, for how long do these patients take dual antiplatelet therapy? And the length of time ideally is 1 year. You keep them on dual antiplatelet therapy. Then after a year, you drop one and maintain them on one antiplatelet. But there is a caveat to this statement. You have to weigh the risk of thrombosis vis-a-vis the risk of bleeding. For patients who have a high risk of bleeding, we can reduce their duration of DAPT, and we give them a short course of DAPT and maintain them on a single molecule. But ideally, what would be good would be to keep them on dual antiplatelet therapy. So we have done that. We have given the patient dual antiplatelet therapy. So the question is, what other medications can we give these patients who have presented with an acute coronary syndrome? And one of the most important medications we give is a beta blocker. Actually, all patients who have presented with an acute coronary syndrome, apart from those who come with an inferior wall myocardial infarction, which we have seen that can be complicated by AV blocks, they should be on a beta blocker. And the question would be, why do we give these patients beta blockers? Number one, we say that beta blockers are anti-ischemic, meaning that they reduce oxygen demand on the myocardium, and of course, with reduced oxygen demand, then they help your patient not suffer either infarct or your patient gets a better prognosis. Then the other issue is that every time a myocardium suffers an infarct, it leaves scar tissue. And this scar tissue is usually a substrate for malignant arrhythmias like ventricular tachycardia. So we give beta blockers and say that beta blockers are anti-arrhythmic. So those are some of the two major things why we give beta blockers. And the other reason why we give beta blockers is for patients who suffer very big infarcts. They may go into what we call heart failure with reduced ejection fraction. So beta blockers would offer them a mortality benefit. Then the third category of medications we use are statins. And please, I'm going to stress this, that regardless of the cholesterol panel of your patient or the lipid profile, meaning that even if your patient has a normal lipid profile, provided they have suffered a myocardial infarction, you're going to give them statin. Then the other medication, the category of medication we use, what we call angiotensin receptor blockers or ACE inhibitors. So patients with, and they say that if the blood pressure allows, these drugs actually should be started within 24 hours of a myocardial infarct because they remodel the myocardium and offer a better survival to your patient. So after you have given those 4 medications, the other things you're going to look at, of course, is comorbidity optimization. If your patient is hypertensive, please control the pressure to target. If your patient is diabetic, HbA1c should be in the target ranges. If your patient is a smoker, lifestyle modification. If they are obese, weight loss management. And of course, if they are smoking, you're going to, of course, counsel them for lifestyle modification. So that basically, that is how we manage a patient who has presented with an acute coronary syndrome. But please, after you have done all those medications, then you have to watch out for complication. And one of the commonest complications of acute coronary syndrome is heart failure. And this heart failure usually, it depends on how large the impact has been. And the patients who usually go into heart failure with reduced ejection fractions are those patients who come with extensive impacts or whose infarct is in the left, in the LAD, which supplies over 40% of the myocardium. Then the other thing you have to look out for is the left ventricular thrombus, which usually forms, as we have had, in the left ventricle, and of course it has risk for embolization. And the other thing that you can look out for are malignant arrhythmias because of ischemia. So in myocardial infarction, we have what we call mechanical complications and electrical complications. So you have to look out for all those complications. At this moment, I can pause here and see if I have any questions. And
thank you, Dr. Mbabazi, for such a thorough and good presentation. There have been several questions in the chat while you were talking, and while you're on, maybe you could go over, some people wanted clarification on the types of investigations that should be prioritized. So there were questions about D-dimers, questions about if you only have one antiplatelet available, which one do you suggest is better used? Same with beta blockers. So if you could answer those questions.
so for such, actually, what I have to really stress is that in acute myocardial infarction, there shouldn't be a role for monotherapy. But if you're really pressed to the wall, I really don't recommend this, but you would give aspirin. The ideal would be for your patient to get dual antiplatelets. But what we know is that aspirin is commonly available, so you can give that as you combine it with low molecular weight heparin as you look for a second antiplatelet. And for which beta blocker to use is that in cardiovascular medicine, what guides you on which beta blocker you're going to use? Please go there. Which guides you on, or what guides you on what beta blocker you're going to use is the ejection fraction most of the time. We know that if you have a patient with reduced ejection fraction, and here we are saying if your ejection fraction is less than 40 or less than 50, actually let's say less than 50, or let's take less than 40, then we have 3 beta blockers that have been studied to have a mortality benefit in patients with reduced ejection fractions. And the beta blockers we use are 3. Number 1, we use carvedilol. Number 2, we use bisoprolol. And number 3, we use metoprolol. Please don't start your patients who have suffered a myocardial infarction and most likely they have low EF on propranolol and atenolol and which other beta blocker do people like. So let's try as much as possible.
Thank you. Thank you, Dr.
So
Mbabazi.
let's try and stick to those three.
Other questions are on there. So I'm going to start going through and asking questions. EKG. Is she going to go over the EKGs? Dr. Mbabazi, you're going to go over the EKGs now?
From what I'm seeing is it's like our time is fast spent, but just what I wanted to show people is how an ST, let me first, how an ST elevation MI looks like. And I thought that I would first show you a normal EKG. And we are interested in this segment from, if we take this as the RS, then T, we are interested in this segment from here up to there. And if you look at the definition of ST elevation, you look at people who are less than 40 years, and we are saying that in the precordial leads, if you have an ST elevation of more than 2.5 millimeters, then that qualifies for ST elevation. That is in patients who are less than 40. Then for those who are more than 40 years, for a man, ST elevation in anterior leads of more than 2 millimeters is significant, and in a woman is 1 millimeter. In a woman is 1.5. That is in the anterior leads. Then any other leads you can use 1 millimeter. So we call that significant ST elevation. And that is why I wanted to show you this EKG. If you compare it with this one, you see that here, some people may be confused and take this as ST elevation, but still another thing we look at is the shape of your ST segment. And as you can see this, you have, when you go to the EKG, you have to look at the isoelectric line and you count the number of boxes that are above the isoelectric line, because here you can clearly see that the ST segment is up. And when we are saying that it is significant ST elevation, we use what we call two contiguous leads, meaning the leads that represent a segment in the myocardium. On the EKG, we say that if we have V1 and V2, then we take those to be septal leads. Then V3 to V4, we take that to be anterior leads. Then V5 and V6, those are lateral leads. Then lead 1, lead 2, and lead 3, we usually take them to be inferior leads. So if you have ST elevation in only one lead, that is not significant ST elevation. It should move in those blocks, followed by what we call reciprocal changes. Where there's an elevation, then in the opposite leads, there should be some ST depression. So thank you very much.
Thank you, Dr. Mbabazi. I hope you guys were able to hear her and her quick explanation on ST elevations and comparing the two 12 leads that we see on the screen. I noticed that there was a hand raised by Toluba Marvin. You're going to be unmuted so that you can ask your questions, and the questions are now open to all panelists, so not just Dr. Mbabazi, Dr. Kani, and Nurse Samal. Toluba Marvin. Oh.
Yeah, thank you. Thank you so much. Thank you, Doctor, for the presentation. My inquiry was about the dose of morphine. I did not get it very well. And also, there are some things that you confuse. As some people say that probably oxygen is not necessary. Some people say that oxygen is necessary even if the saturation is above. So I want some clarification on the dose of morphine and then the importance of oxygen therapy. Thank you so much.
So thank you, Toluba. You can give 2.5 to 5 milligrams per kg of morphine. Sorry, not per kg, 5 milligrams of morphine. You can titrate it to response and depending on your patient's weight, really. Oxygen therapy, routine oxygen therapy is not necessary. You only give it if your SATs are less than 93. But routinely, we don't recommend routine oxygen, low oxygen.
Okay, thank you, Dr. Connie, for answering the question. I see Gillian Park has his hand raised. You're going to be unmuted to be able to ask your question. And Dr. Mbabazi, please feel free to unmute yourself if you need to add anything to any of the responses.
Yeah, sure, I'll do that.
Gillian Park. Okay, we're now going to give the floor to Kamonga Dixon to be able to ask your question to the panelists.
Yeah, hello. I hope you can hear me. Yes, moderator, just confirm that you can hear me.
Yes, we can hear you.
All right, great. Yeah, my name is Dixon Kamoga. I'm an emergency medicine resident at Macquarie. Yeah, so mine is not really a question, but rather I would just love to contribute to the discussion. And really my point goes to us who are involved in advanced management of patients who have acute coronary syndrome. So I just want to add a thing to the discussion that for patients that have inferior MIs, like we saw in this case, they're usually associated with a right MI, and most times you're going to miss it. So the reason for this is the culprit vessel, that's the right coronary artery, is the same that supplies the right ventricle. So because we don't have an actual lead that sits over the right ventricle, we may not have a way of telling that the patient has an associated right ventricular MI. So usually the only pointer to this is maybe you're going to look at a V1, and if there's an ST elevation in V1, because yeah, practically that's like the only lead which sits over the right ventricle. So if there's like an ST elevation in V1, which most likely may not even be there, that could be the only pointer to a right-sided MI. So what's done in that particular situation is there are quite actually a number of approaches that can be done for you to be able to pick a right MI. So what's done is we do a mirror image of what has been done on the left. So you lift all the leads that were on the left and put them on the right, just in the mirror image of that. So you're able to do a right EKG and pick a right infarction. So the reason why it's important for us to know that the patient has a right MI as well, a right-sided MI, is because these patients are managed quite differently from the ones that have just a purely inferior MI. So those ones are usually volume dependent, and drugs that are going to reduce preload are going to further worsen their prognosis. So for those particular patients, avoid the nitroglycerins, and really their only chance to life is really expanding their preload. So they'll be volume sensitive, and yeah, so that's why it's important to know that the MI on the inferior aspect of the heart is associated with the right. Yeah, so yeah, basically that's the contribution I wanted to add to the discussion. Thank you. Over to you, moderator.
Thank you for your contribution, Dr. Dixon. Dr. Mbabazi, we're
Yes,
gonna.
a small correction to Dr. Dixon is that in V1, he's going to look for ST depression, not ST elevation, to show him if there is posterior extension. And the other clues he talked about, of course, this patient will be very hypotensive. The GVP will be elevated, the liver will be large and tender, but when you listen to the lungs, that patient will have a clear lung. And those are some of the indicators that will show you that your patient has a posterior extension of the posterior wall tumor. And we thank him a lot for pointing that out.
Dr. Mbabazi, maybe you can expand a little bit. A lot of people have been asking questions about the use of nitroglycerin. And I think possibly because the case study we had a patient with an inferior MI and that was hypotensive. So maybe you could clarify the contraindications for the use of nitroglycerin and why we use nitroglycerin in the management of acute MIs.
So the reason why we use nitro in the management of acute MI most of the time is, of course, you know, if there is a constriction, if you give a nitrate, then the vessel will dilate and you will reperfuse and take away the chest pain. But the problem is that we know all nitrates, they cause a lot of hypotension. So if you already have a patient who is hypotensive, and very unstable, you don't want to give them a drug which is going to make them more hypotensive. And that is why we don't use nitroglycerin in patients who are already hypotensive, because it will practically worsen the hypotension.
Thank you, Dr. Mbabazi. Another question that can be put to the panel is, our participants wanted to know the management of cardiogenic shock, which is a bit expansive, but yes, the management of cardiogenic shock.
Actually, if you have a patient with an acute MI and they present to you in a village hospital with cardiogenic shock, most of the time the patient is in trouble, and as well as the healthcare practitioner is also in trouble, because the management of cardiogenic shock in acute coronary syndrome is really advanced, and at the moment in Uganda, even at the Heart Institute, we are a bit limited, because those are the patients you've heard about, things like ECMO, who will require such things. There will be patients who will require like left ventricular assist devices to help them, which are not here. So if you have a patient who is really, really in shock, one of the best things that you can do for that patient is to reperfuse the patient immediately. If you are unable to reperfuse the patient and reverse the ischemia, then as I've said, the patient is in trouble and also the doctor is in trouble. Because the next option that you have is going to be the use of inotropic support, or the vessel, or you're going to press your patient with inotropes. And remember that most of these inotropes, they cause tachycardia. So you have a patient who is in shock, you have put them on inotropic support, you have made them tachycardic, you have increased the oxygen demand, you're worsening the ischemia. So generally the management of cardiogenic shock in the setting of acute myocardial infarction is very complicated and falls under the management of advanced heart failure. That patient needs a lot of support. The best we can do, you have to reperfuse. If you cannot reperfuse, then that's a patient who should be managed in an ICU. It has to be managed in a center which is higher than a high dependence unit. And most of the time, that tells you that the patient has suffered an extensive myocardial infarction, and prognosis of that patient is usually poor. And that is why we stress that the earlier you save the myocardium, the better for the patient, because prolonged ischemia with usually most of the time leads to cardiogenic shock, and those patients usually don't do well. So it is a tricky situation for a health worker to find themselves faced with such a patient. The options are really limited in our setup.
Yes, thank you, Dr. Mbabazi. Dr. Asia, please feel free to add any comments to the presentations or anything you would like to add from the environment you work in. And just a reminder to our online participants that the post-test is now up and you can take it. Remember, the pre-test and the post-test are the same. So if you took the pre-test in the beginning, you're going to take the post-test. It's going to be the same questions and the responses will be shown after. Thank you. Dr. Asia, any comments?
Yeah, hello again. Thank you, everyone. Just as an emergency resident, I'm really concerned with early diagnosis of acute coronary syndrome. When we talk about acute coronary syndrome, we are talking about the leading cause of death globally, according to
Dr. Asia, could you raise your voice a little bit more? We can barely hear you.
Is it clear?
No, you sound farther away now.
Can you hear me clear now?
Yes, that's better.
I said as an emergency resident, I'm concerned with early diagnosis of acute coronary syndrome. Acute coronary syndrome, we are talking about the leading cause of death globally. According to last WHO study, 16% of all are due to ischemic heart disease. And unfortunately, it is the second most commonly misdiagnosed acute medical condition. At the time of diagnosis makes great difference in outcome. I always say one should be suspicious when it comes to acute coronary syndrome. This particularly with low experience in dealing with acute medical condition. We should raise awareness about different atypical presentation of acute coronary syndrome and patients with chest pain or chest pain surrogates like dyspnea, epigastric pain, discomfort, panic should be considered an acute coronary syndrome patient until proven otherwise. Okay. Absolutely no one would miss an acute coronary syndrome patient presented with typical chest pain, but about 30% of acute coronary syndrome patients present with atypical presentation. Okay, we call them chest pain equivalent, or as Dr. Mbazi said, pain from eye to abdomen. It is acute coronary syndrome until proven otherwise. From my experience, one of the confusing things is the partial response to PPI in patients presented with gastric pain of cardiac origin. Many times I see patients who checked in PHC for gastric pain. They were vital well. ECG may be missed or done, but it was normal or showed non-specific change. So the patient received PPI, partially improved, and now doctor and patient are reassured a patient discharge on oral PPI. But unfortunately, this was not the end of the story. The patient then rechecked in the ED for increase in pain severity or P-associated symptoms maybe appeared, and patient diagnosed as MI after maybe 12 hours of pain onset. Okay. So you should be very suspicious about acute coronary syndrome. This about my experience. I found we already suffered from late diagnosis of acute coronary syndrome, especially those who presented with atypical presentation. Thank you. Also, one of the things I want to talk about in last European Society studies, it is missed in female more than male, because classically it is MI is a disease of man. Okay, but last time it get changed, and 5% of women with acute coronary syndrome were initially misdiagnosed. So just get care. I just want to.
Yes, thank you. Thank you, Dr. Asia, for reiterating the differences in atypical presentation and non-typical presentations of ACS. Thank you so much. We're out of time. I hope you guys were able to continue to answer the post-test, and you should be able to see the links. You should be able to see the links that allow you to be able to see this session again. Gillian Park, you were given the chance to speak before. I hope you can speak now and be able to ask your question. And that will be our last question of the session. Gillian, you've been unmuted to be able to ask your question. Okay, we can't hear you. I'm sorry, we're out of time. If our panelists don't have any final remarks that they would like the audience to go on with, anything anybody would like to add before we close our session?
Maybe as we close, we should remember time is muscle, time is myocardium. Let's be vigilant. The quick history will save this patient. People were talking, what's lytic therapy? Lytic therapy is fibrinolysis, breakdown of the fibrin or the clot. And that's using the different mechanisms, whether it's mechanical or pharmacological. So let's be vigilant. Let's watch out for acute coronary syndrome or MI. It will really save these patients. Thank you.
Marcel?
Yeah, my comment is on quick referral, please. I saw somebody asking the phone number of Dr. Happy. Get in touch with, you must be able to have contacts of those centers in Kampala which can do PCI and be able to reach out to them before you even send the patient. Some of them don't work 24/7, but when you call them, by the time it reaches, you will find them ready for the patient. Thank you.
Thank you. And just to reiterate what everyone has said over and over, please do your basic assessment, A, B, C, D, E, and figure out what's life-threatening to your patient and treat accordingly. Dr. Mbabazi, if you have any final comments before we end?
Well, my final comments is that it has been an interactive session and we want to really appreciate our online audience for the engagement. And I usually live with a quote from the Bible which says that my people perish due to lack of knowledge, and every time we have such sessions, we reduce on our risk of perishing. And we really extend my appreciation to the people who invited me to be part of this session. Thank you very much. We meet again in the next session.
Thank you.
Right.
What about
Thank
Dr.
you.
Solomon? Dr. Solomon, if you have any final comments? I see he's still on. I see it did.
No,
Yes,
you can hear me?
yes, we can.
Well, thank you so much for the clarification that was already raised on my presentation. I think I got where necessary the hiccups where we had not met the expectation for the patient. Maybe the other issue I wanted to raise was about the timing of presentation of these patients. At times, like this other case we had was 2 hours after, came 2 hours after the chest pain. So meeting also the 2 to 6 hour target of lytic therapy, I think might also be a challenge as far as upcountry patients are concerned. Other, thank you so much. It has been a big bunch of knowledge picked, and yeah, I'm grateful.
Thank you, Dr. Solomon. I want to thank everyone who logged on and participated in this echo session today. I think now is the time for the screenshot picture, or was that done already? Okay, so thank you, everyone. I hope you have a great weekend. And again, remember the links to all of this were put in the chat so that you can revisit it as needed. Thank you to our panelists and have a great weekend.
Thank you.